The modern endurance athlete represents our ultimate health ideal. We assume a body constantly in motion houses a cardiovascular engine completely free of rust. To test that assumption, researchers turn to longitudinal registries, like MARC and Master at Heart, using high-resolution imaging to look inside the arteries of lifelong endurance athletes. The scans revealed that lifelong athletes actually carry a higher prevalence of coronary plaque and higher calcium scores than healthy people who are completely sedentary. These athletes also showed higher odds of having non-calcified, lipid-rich plaques sitting in the proximal segments of their coronary arteries. This is the exact type of soft lesion normally found in high-risk cardiology patients. This chart compares how different training habits affect plaque progression. Look at the flat line. That measures total weekly volume, the hours spent running or cycling. It shows no significant association with plaque growth. But this spiking line represents exercise intensity, pushing the body into very vigorous zones, above 9 metabolic equivalents, directly tracks with more plaque accumulation. The biological toll comes from extreme pressure. During a heavy workout, a well-trained athlete's systolic blood pressure can surge past 200 millimeters of mercury. This repetitive, heavy mechanical stress against the coronary wall creates turbulence, allowing inflammatory white blood cells to stick to the boundary and build plaque. We are left with a contradiction. If pushing the human body to its limits builds the specific plaques associated with heart attacks, why do endurance athletes have significantly lower cardiovascular mortality than the rest of the population? The earliest clinical evidence of physical activity protecting the heart came from a natural experiment on the streets of 1950s London. Researchers tracked over 31,000 transport workers, comparing two specific groups. The bus drivers sat completely still for their entire shifts. The conductors were constantly on their feet, climbing hundreds of stairs every single day. Both groups were men of similar age, sharing the exact same post-war diets and socioeconomic environments. Yet the conductors experienced roughly half the rate of sudden cardiac death compared to the drivers. A person's environment establishes their baseline risk, but moving throughout the day alters how that disease clinically manifests. The motion protects the heart before it ever physically removes a single piece of plaque from the vessel walls. For decades, cardiologists relied on invasive angiograms to map the heart. But an angiogram only creates a silhouette of the blood path, the lumen. It leaves the actual vessel wall invisible. This is a cross-section of an artery, illustrating the Glagoff phenomenon, or positive remodeling. As plaque accumulates inside the vessel, the artery's external boundaries expand outward to compensate. The central hole where blood flows stays completely clear. Because the blood path is maintained, a standard scan shows a normal-looking artery, even when it harbors a massive amount of hidden, vulnerable plaque. The vessel only begins to collapse inward once the plaque burden crosses a 40% threshold. Exercise intervenes directly on these walls through fluid mechanics. Chronic aerobic training increases blood flow, which generates high wall shear stress. This is the physical, frictional force of rushing blood scraping against the inner lining of the artery, signaling the surrounding cells to suppress inflammation. Under the constant, repetitive strain of a high heart rate, the body reinforces the site. It forces those soft, lipid-rich plaques to calcify, converting vulnerable lesions into dense, stable scar tissue. Intense exercise does not scrape the arteries clean. The exertion acts as a structural engineer, forcing the vessels to grow wider to maintain blood flow and hardening the existing plaque so it won't rupture. Modern AI-enabled imaging from the PROMISE trial reveals that these structural rules apply differently to men and women. Women generally have smaller coronary arteries than men. Because the total volume of the vessel is smaller, a tiny amount of absolute plaque creates a much larger relative blockage. This graph maps the exact threshold where cardiovascular risk begins to climb. For women, that baseline risk emerges at a 20% total plaque burden. For men, the same risk level doesn't hit until 28%. Applying the same universal safety cutoffs to everyone severely underestimates the danger for female athletes. Despite these differences in volume, the core paradox remains true. At high doses of physical activity, the sheer amount of plaque in an athlete's chest detaches from their actual risk of dying. A lifetime of intense exercise accelerates a biological healing process. It rapidly converts dangerous, unstable fat deposits into benign, hardened calcium. Preventive cardiology is moving past the simple binary of whether a patient has plaque. The most accurate measure of cardiovascular health is the physical width of the vessel and the structural density of the defenses built inside it.